So I think the objective is we try to understand, because understanding the pathophysiology of shock, I think it's very important, because it will really tailor the way that you're going to approach and how you're going to intervene. Understanding what kind of shock you're dealing with and what is the stage of shock, I think that's very important. If you are dealing with the end stage shock, then I think most of the things that we do is not going to work. The last thing is, I think this is all related, is once we understand the pathophysiology, we understand the stage, then we can choose which option of intervention we can go with. Shock is well defined. There are multiple definitions, but we generally agree on this concept that it's a state where it's characterized by a significant reduction of systemic tissue perfusion, where the demand and supply are mismatched, and you start to get into the stage of what we call cell death and organ damage, multi-system organ failure, and death. The definition itself is the stages by itself. So if you go and you continue reading this definition and you have finished the definition, it's too late to intervene. Because when the cell die and the multi-organ failure comes, and I think the last one, which is death, is actually just an outcome. And it's going to come because the multi-organ failure is very difficult. So if the secret of treating cardiogenic shock is actually to intervene early and to have a sense of prediction and try to know where are we exactly. I think this diagram, which is very important, if we understand this, if you look at the myocardial infarction and you get the myocardial dysfunction, the result of myocardial dysfunction is that you have a systolic myocardial dysfunction. This results in reducing the cardiac output, reduction of the diastolic volume, and of course that leads to reducing systemic perfusion, the hypotension. This will also worsen in the situation, and there is decrease in coronary perfusion pressure, and of course this will lead to stimulation and release of compensatory vasoconstriction, trying to elevate the blood pressure, and lead to progressive myocardial dysfunction, and this is a circle. The worst part of this circle is this one. This one that we don't really see, and we cannot, most of us do not measure, is the inflammatory markers and the systemic inflammation that come with cardiogenic shock. And if you reach to this stage with a profound systemic inflammation, it's maybe too late. What we're trying to control is we're trying to interrupt this cycle by doing some sort of revascularization. Hopefully we'll relieve the ischemia, and by relieving ischemia, hopefully we can cut this or interrupt this cycle of continuous damages of the cell and progressive myocardial dysfunction and eventually death. The cardiogenic shock mortality is very high. In the best scenario, I mean, we used to say 80%. Now with revascularization strategies, we think cardiogenic shock reaches a mortality of about 50% at 30 days. Early revascularization has generally been associated with a better short and long-term outcomes. I'm going to illustrate on this and show you some couple of diagrams. The hemodynamic support that we talk about, which could be sometime achieved by inotropic support and vasopressors, or we have to go into what we call mechanical means, which is there are different options. I'm going to try to illustrate and review some of the evidence behind these, which is the intra-aortic balloon pump that we had for years and years, the new percutaneous LVADs, and of course the ECMO, which is quite extensive and time-consuming. The outcome has been well defined, and this is from the shock trial. I think the shock trial, we all know the shock trial, and we talked about it. I was shocked to see that the FAME is, the first slide of FAME was 2001. And I felt very old because I remember the FAME very well. It's 14 years back. Oh my God, this is scary. And now the second FAME is 2007, and they got this 2012, which is all has been several years back. Anyhow, the shock trials, which is a few years back, showed us clearly that early revascularization changes the outcome, and it has been persistent. You're talking about the number of years. So really, if you get the patient and revascularize them early, then you're going to change the outcome. The American Heart Association, the American College, put some diagrams and some algorithms trying to make this simple, as our colleague showed us the acute STEMI algorithms, which is make things very easier. If you get cardiogenic shock and you have the early shock diagnosed with the hospital presentation, you have to get revascularization strategies. The use of intra-aortic balloon has been changed in the guidelines recently. I'll talk about it, and it's been downgraded. The delayed onset shock with mechanical defect, that's a different thing. You need to go for maybe surgery. And here comes the revascularization strategies, doing the infarct-related artery in patient who is stable. I think that's very reasonable. Now we say a simple non-culprit vessel is also reasonable. And that in cardiogenic shock, the shock trial have showed us that maybe we should try to be and do most of what we think are prognostic vessels and try to achieve as much complete revascularization as possible. The supporting devices, I'm going to try to focus on these ones, and I'm going to take you to the supporting devices that we know. The intra-aortic balloon pump, that's the old one. We have the Embella, which is the left ventricular percutaneous femoral or biosurgical cut down. And we have, of course, the ECMO, which is the now becoming more user-friendly, but still need a lot of technical support. And the advantage of ECMO, we'll talk about it. And you have the Tandem Heart, which is sort of a rotatory pump that attached to the patient thigh through a transeptal and give you some cardiac support. There is really limited data when it comes to supporting devices, and this is good and bad at the same time. It's good because if you want to use it, you can use it because there is no much of data about it, and it's a life-threatening condition, and you have to use it. It's bad because you don't know, are you doing good or bad? So it's really, it helps you and doesn't help you that much. But the guideline recommendation are generally some experts' opinion, and some it's all grade C. Recently, some European guidelines came out, but still there is no clear direction. I think the intra-aortic balloon pump is one of the oldest. It has been there since the 60s. The intra-aortic balloon pump, we all know it's a catheter, it's a balloon, you put it, it's easy, it takes like 5 minutes to get it in, maximum 10 minutes. And the balloon actually, we thought it's actually provides some sort of inflation during diastole, improve myocardial diastolic flow, and deflation during systole reduces the peripheral vascular resistance, improving cardiac output. The real difference is like 0.5. It really supports the cardiac output by about 0.5 to 1 liter per minute by maximum. The change between with or without the intra-aortic balloon pump. There are some modern systems which become more easier, smaller catheters, smaller sheath, less bleeding complication. We're not seeing the peripheral complication of the intra-aortic balloon that we used to see before. It's become more easier and nicer. There are a couple of registries which was supporting the use of the intra-aortic balloon. I guess the one of the biggest was the Gusto-1, and then came the shock trial, and the shock trial showed us that yes, people who got the intra-aortic balloon did better versus the people who did not get the intra-aortic balloon. And we believe on that, and the American and the European guidelines put it higher on the guidelines. But when SHA-2 trials came in, and it clearly showed the intra-aortic shock trials clearly showed that there is no benefit, and this led to downgrading the intra-aortic balloon from the guidelines to a lower level. So when you look at the SHA-2 trials, which is about 600 patients, the actual difference was there's more vascular complication with the intra-aortic balloon versus the patient who did not get the intra-aortic balloon at 30 days. This was one of the nails in the coffin of the intra-aortic balloon. In spite of this, people are familiar with it and they still use it, and they don't really want to stop, feeling that they have done something for a patient with shock. I think it's more of a psychological support to the patient and to the doctor rather than to the patient. The ECMO, which is, I'm starting with the more complicated one. The ECMO is supporting vascular and oxygenation, and the ECMO is more extensive way of support. There are some newer systems, which is the LifeBridge and the CardioHelp, which is, these are new systems. They have some special, and they are portable, and they have special smaller catheters, but you still use a very big 16 to 19 French arterial cannula, which is very invasive. But in the same talk, it gives you a good cardiac output up to 7 liters per minute. The problem with ECMO, as we all know, you need a perfusionist, you need people who are, and the physician and the intensive care unit to know how to handle the ECMO and the ECMO problems, and it will be very difficult to have it in the small hospitals or small centers, so you need really to be in advanced centers. The Tandem Heart, which is an active LVAD, Tandem Heart has been introduced to Saudi Arabia just in the last year and a half almost, and the Tandem Heart, it's as I said, it's a rotatory pump machine that you attach to the thigh of the patient, but you use a left atrial cannula where you go through the vein and you go transseptal, and you sample the blood from the atrium, not from the ventricle, and you pump the blood back toward the increasing the cardiac output. The problem with the Tandem Heart is that it needs special training. It also needs a perfusionist to be able to handle the machine, and it does not solve the issue of oxygenation as the ECMO, but it provides a very good hemodynamic support. Again, randomized trials are not there, but there are registries who looked at different outcome with the Tandem Heart. One of them showing about 50% reduction in about 40 plus patients, 50% reduction in mortality of cardiogenic shock, comparing Tandem Heart versus no Tandem Heart. But I still think that we don't have much of data on it, but the outcome generally of this condition is not good. And I think anything that you can do once you are familiar and confident of what you're doing is reasonable considering the cost of the procedure. I'm going to just, for the sake of time, go to the Impella. The Impella is maybe the most reasonable of all, because it's less invasive, it's easy to do. It takes about 10 minutes to put the Impella. The Impella is basically a rotatory catheter. So the Impella has 3 types. There are the 2.5, the 5, and the new one, which is the CB, provide 3.5 to 4 liters per minute. The 2.5 is percutaneous. The CB is percutaneous. The 5, you need a cut down. It's a surgical cut down. The one that we use currently is the CB. We're not using the 2.5 anymore, so we use the 3.5 to 4. It's a 14 French catheter, and the system has a mounted big tail catheter. It's tipped, which placed via the aortic and the left ventricle. So basically, it's a big tail catheter with a pump or a rotatory pump that you deliver it through the femoral artery all the way up across the aortic valve, where it sucks blood from the ventricle and pump it out through the aorta, descending aorta. As this is what I just described, the maximal pump with a rotation rate of 50,000 rounds per minute delivers the blood to the ventricle. And there are smaller study comparing the intra-aortic pump versus the Impella, and I mean, they're showing better hemodynamic improvement, but it's very difficult to come up with a solid endpoint of these trials. I mean, if they improve the hemodynamic, then you assume they're going to be better. But you don't really know, and it's very difficult to randomize patients anymore. I think it's going to be, it's a condition which has a higher mortality, and sometimes you have to do what you need to do. The data of the Embella is encouraging. There are some complications of Embella that need also to be considered. Remember the vascular complication, you're putting a 14 French, small ladies, they have to have a good femoral arteries, and so ladies and people who have peripheral vascular disease, you're gonna lose their limbs possibility. The likelihood, they say it's small. I personally, for the unfortunate, I had one patient, she lost her limb with an Embella. The thing is, she survived, but she survived without a limb, which is not very good. So I don't know what was it right or wrong, but we tried to save her. The observed bleeding rate in this study were similar with the Embella Euroshock registry, which is similar to the standard acceptable rate of bleeding. There are some reports where they combine the ECMO with the Embella, trying to provide the oxygenation part and reducing the right side pressure, because the Embella cannot handle this, and be less invasive on the other side. And these are just case report, although sometimes it makes sense in very advanced cases. I'm talking about this is the use of Embella versus the intra-aortic balloon pump. This is in a stable patient for high-risk BCIs, where this is my current practice on patients with high-risk BCI. We use the Embella as a protection for us in severe LV systolic dysfunction, multi-vessel left main, and we're not using the intra-aortic balloon pump in our center anymore. The Embella 3.5 is the one that we use. This is a comparison between the intra-aortic balloon and the Embella, showing the superiority of Embella of major adverse events between the intra-aortic balloon and Embella in stable patient, not in cardiogenic shock. I still, again, repeating this because this is not a shock trial. The conclusion for me is, honestly, the shock is a very difficult condition that we deal with. And what we try first to do is we try to risk stratify patient the moment I receive the call, and think how I'm going to risk stratify this patient. What's the patient age? Is he older than 75 or not? What's his other comorbidities? What's his kidney function, which is one of the strongest predictors? Is this patient has passed through the stages of shock and he reached a stage where there's cell damages and multi-systemic failures, where I think intervention has become very little, and I think losing him is the likely end of that scenario. So I think interfering in the early stages and early revascularization is the key to success. And revascularization in early stage may actually interrupt that cascade that we talked about, and I showed with that systemic inflammatory mediators and the worsening of his other organ failures. The supporting devices is something that left to the person and to the center experience, because I think the intra-aortic balloon is becoming out of favor and losing its ground day after day and study after study now. And with the becoming of newer one, which is more user-friendly, and in particular for me, the Embella 3.5, where it gives you a good 3 to 4 liters of cardiac output, in addition to lower risk of complication comparing with the Tandem Heart or the putting patient in ECMO. I would like to stop here and thank you all.